We're wearing this because we're using the Misonic, so it squirts everywhere, but we're getting ready for a very interesting lecture. One of my colleagues, a senior guy, Ed Abrahams, he used to say at the start of his career he fused, then he refused, and now he refuses to fuse. So
Very good.
Goes with your theme of what you've been showing, and I think obviously fusion disease is a difficult problem that we all have to address. And there's nothing like follow-up to see our true results. So what we're going to try to do here in the lab, we'll get the camera in for everybody to see. I got Colin here.
Hi, Colin. Do you have a voice?
Yeah.
All right. Where are you from, Colin?
University of Iowa.
Excellent. Glad to have you here.
So what we're going to do is we're going to do, I don't know if everybody can see. So this is L1 that we have exposed here. We have screws in 12 and L2. And we started the decompression. And what we're going to do, he's going to use the Misonics here. It's a really nice cutter, and it cuts just through the bone and spares the soft tissue. So we're going to turn that on right now. I'm going to cut just to release it out. This will be our first part of our decompression for our osteotomy.
I've tried it a couple times. I still use a Midas.
And a Karis.
And a Karis, yes.
At the top, you need to do just a little bit more at the top here. Okay, so I'm just going to do the first part here is we're doing the laminectomy. So we took off the bottom of 12, all of 1, and some of 2 here, and that's what we're going to see. So what we're going to do for today is osteotomies, and so we're going to, I think the best osteotomy to show would be a hemiosteotomy, just because it's not done that commonly. And then it's a combination of a Smith-Peterson osteotomy, which we'll do on this side, type 2 osteotomy, and a type 3 on this side. So what we're going to do is we'll start that out. The first thing we do is the decompression part. And you can see that we've isolated the facet joint right here. So this is the facet joint at 12-1. So that's the inferior facet, and that's the superior facet. And we have the same on this side. And then what we're going to do for part of the osteotomy, the next part is to isolate the pedicle for the pedicle subtraction osteotomy. So we have the pedicle with the hole with the previous screw, and we're going to separate it from all its bony attachments. So the lateral bony attachments is the transverse process, the proximal end is the superior facet, and the bottom part is the pars. And as soon as he gets rid of the pars, the inferior facet will fall off, and we're going to do, that's the first step we're going to do now is isolate the pedicle. So do you want to cut the transverse process? Just let it cut. Okay. So perfect, yeah. So just show with the blade. So this is the Misonics. We have 2 types of blades here. This one is a straight cutter, and there's a 25-millimeter length, and we use it to cut through the lamina. This one is shaped like a Kerrison, and you just use it like a Kerrison, and so he used it right across here, and he's going to do it again, just as if he's using a Kerrison. He's going to separate and cut the pars out, and we'll find the nerve root right underneath there. So it cuts really nicely, usually not associated with much bleeding. Come right through the pars. He's going to cut right over the nerve root there. Okay. Is he through?
There's a little bridge.
Okay. And then he's going to separate the superior facet. So you're going to come in this way over the pedicle and take out the superior facet here. Okay, so now we're going to take out these bones. So right now the pedicle is going to be isolated from the bony attachments here. Are you through here? We'll use this. You got it? Okay, let's give it a shot. So now he's gone through the pars, and then the inferior facet now is not attached to anything, so it comes right off. And then you're left with the superior facet of L2, and we're just going to separate now. So this is the superior facet that he's cut off, and the transverse process. So now we have an isolated pedicle. And the most important is to make sure the nerve root is nice and free. So that's what we have right now. Yeah, I'm sorry, it's in my head. So now what we're going to do is we're going to just get rid of the rest of this pedicle. I have another sterile one coming. Okay. Thanks. So what I want you to dissect the nerve root off the pedicle there.
Can you watch your head? Yeah.
Okay, sorry guys. So we're going to do
Dr. Lewis, how loud is this device? Are you going to get some high-pitched hearing loss, or are you wearing some earplugs or sound protectors?
No, it's like when you come home late from work. It's similar to that. So.
Note that there was loud laughter in the audience. Much appreciate this late hour.
Okay, so what we've done now,
Yeah.
so I'm going to take the top of the pedicle off.
Is this an ultrasound, Roger? Is this an ultrasound Lexel?
No, this is it's a vocal one. It's just a regular one. Okay, so he's going to separate the nerve. So what we have now is the pedicle separated. So you can see here, maybe, Colin, you have a better position because my head blocks it all the time. So just show, so we have the nerve root here isolated. I don't know if, does that show up nicely?
Yes, it shows.
Okay, and you can see the pedicle isolated here, and we still have the top of the pedicle here still available. So this is the inferior facet, superior facet's removed now, and now we have basically an isolated pedicle and the nerve root. So we've separated the transverse process off. And the next thing I like to do is basically just slide down the pedicle a little bit, and you can get quite anterior here. And if you stay on the pedicle, you stay away from the vessels. And then on the other side, there's usually a nice venous plexus that runs. I don't know if you guys can see it, just medial to the pedicle here. So we'll spend some time. You can see the nice vein here. Does it show up on the?
Yes, we see it quite nicely.
Yeah.
Actually.
And so now's the time to take out your bipolar instead of your osteotome and work hard on this vein here. And work. I usually follow it all the way up. It goes up above the pedicle, medial to the pedicle, and then just underneath the nerve root. And this is the time to really, this is really what controls your bleeding. You can see they're really nice big veins, and they're in the way, and they have to go. So spend your time now isolating out these out. So what we have now is I have an isolated pedicle with the nerve root with no other bony attachments except for the body now. So our next move is going to be to move the nerve out of the way. Now, if you want a big osteotomy, so what I like to do is at least have to subtract the pedicle. But if you need more, then you have to come into this zone here in the foramen and work underneath the nerve root. But I usually do this cut first here. So if I want, and see how much I can bring the nerve down, usually that would be enough. And if I want more, then I'll work over here and come over, make a second cut over here. So that would be, so I'm set up for the PSO on this side. On this side, we're going to do the Smith-Peterson osteotomy. And basically, we're going to just separate the superior facet from the pedicle. So do you want to use this?
Sure.
So do the same cut over the pedicle on this one. I will try to give him some good help. Okay, so the superior attachment of the bone, the proximal attachment of the bone to the pedicle will be the superior facet. And so if you just come right above the pedicle, you're going to separate the superior facet all the way from the from the pedicle, and that will release. If the superior set comes out, all the ligamentum flavum attaches, it come out, and you get a very significant release on the posterior column. Okay, you through? Okay, and we'll just for, take a hammer. Here, hammer me there. Okay, and again. Okay, yeah, keep going. Okay, so that's the superior facet from the pedicle. Here, one more time, a little shot. A little more. Okay. So that's the superior facet completely detached off. Gives you a significant foraminal compression, and it's completely relieved off your pedicle. And that's, to me, that's all I need for a Smith-Peterson. So take this off too. You got it? Perfect. Okay.
Yeah, like so.
And then just take this off here. Yeah. And I try to leave the inferior facet. So here, take a kerosene. And just take the rest of the ligamentum flavum. Not the bone, just the, yeah. And just cut underneath. Perfect. Okay, and there's still a little more ligament, so you want to get all that out. So it's kind of a decompression of that joint. Perfect, just undercut a little bit more. Okay, so this will free up this side over here. So now we have the Smith-Peterson finished on this side. That's all I really need to do. Thanks. And that'll be our release on this side. Okay. I'm sure you're all asking when the dural tear is going to happen, so hopefully not. So, okay, so right
Since
now
you talk about that, Stephen, you do this under neuromonitoring, obviously.
yeah, it's all under
tensions,
neuromonitoring.
of course.
Sure, yeah, and even more, for lumbar roots, we actually do direct nerve stimulation. So if you take your probe and put it on the nerve root, it should stimulate at about 1 or 2 milliamps, and you can tell if the nerve is unhappy because it'll need more milliamps to get the same stimulation. So usually after every step, we would stimulate the nerve root for a lumbar root just to see what we have. And you can see here is the nerve root and then the dorsal root ganglion over there. So we do a little more retraction than we do, but we try not to. So we have special nerve root retractors to help put a bit of a wall up there. So that would be, here, hold that there. So I'll use the Misonics to get started. Now what I'm going to do is I'm doing a hemi PSO, so I'm going to be aiming it this way. So all my cuts are going to be going that way. And if I want to do more lordosis correction, then I'm also going to be cutting back to front this way instead of straight. If I want more like a VCR, I'm going to cut it straight. If I want some sagittal correction, I'm going to cut it at an angle. So this cut's going to come from here.
And Stephen, do you protect the front of the spinal column? Do you put like spoons around?
Yeah, so yeah, we designed those spoon retractors for the, in the lumbar here, I don't have to worry about it so quickly because I'm not going to go all the way through on this kind of osteotomy. On the thoracic, I definitely always, the first step we do is to put those spoon retractors right across. Generally in the lumbar, we would take this right down here, and if you slide down the pedicle, you can feel his osteophytes in the front. And then we usually put this like this, and I have, if you do it at the level of the pedicle, it's above the nerve root, it's above the vessels, and it gives you a nice retraction here, and it gives you a better understanding of the depth that you're going to have to deal with for the thing. So I usually do it exactly like this here, and then we do have a spoon retractor that we can put in. But that's kind of what it would look like, sliding down the pedicle. We don't have the full PSO set here today, so. Okay, but since I only have one retractor, we're going to use it for this for now. I'm going to take it like that. So my osteotomy is going to be coming in on this angle here. So we're going to do a PSO on this side, and it's going to come out to an angle on that side. Okay, so I want you to take the nerve root gently. Don't show Dr. Chapman.
We can't see. Your head's in the way.
So we're going to make this here. Start cutting the body. And then we're going to separate the pedicle out, and then this cut's going to come above the pedicle here. So we're going to dissect out to find this nerve root as well. I have a special L osteotome that fits right. This will go right inside, top down to the disc there. And then just to make it easier, we're going to take this part out right now. Okay, so now we have basically a release here on an angle. And give it a little tap. And we're going to take out this part here with the pedicle. Okay, so now this whole thing is loose here. So I've taken out the pedicle and the lateral body here in a triangular fashion. So you can see it's angled as a triangle. I want to take that out, Colin? Okay, so you can see we have a nice cut through the lateral body in a triangular fashion here. And now what we're going to do is we're going to keep that cut going on both sides all the way through. So I'm going to leave the posterior wall. Is there a smaller osteotome? So I have a small osteotome here. We're going to work under the posterior wall. So we're leaving the posterior wall intact. Hammer. And we're aiming to the other side now. And so that's going to thin out the back wall. And so the back wall will be nice and thin. And now I'm going to cut into the body. So I'm going to be cutting my wedge into the body. So this is going lateral to medial on an angle, on a triangle. And in this case, on a hemi, the next one's going to come through the disc space over here. Hammer. So that's above the pedicle into the disc space, and you can see the end plate, and now here's the top of the vertebra coming out. Okay, so I don't know if you guys can see. So what I have here, can you guys see?
Yes, quite well. Big
Okay, so here's the lateral wall. So I'm going to triangulate that a little bit more. So we're going to osteotome this. And again. Okay. The pituitary or something. You want to take that out? So we've taken out the lateral triangle, and we're going to medialize it. That's it. Yeah, leave that alone. Okay? So I don't know if you can see down in the body here. Where's that retractor? Okay, so we're all the way through here. We're cut a triangle. This is the end plate of the 1-2 discs. You can see the 1-2 disc. We'll take that out. Or the 12-1 disc. Here, you got it? Okay, perfect. So we can leave that for now. And we're going to keep the cut coming lateral to the other side. And I'm going to go through the disc space again with this one. Okay, so now I'm all the way underneath dura. Pituitary again. And so the body's decancellated in a triangular fashion, and the posterior wall is still intact. So that gives you that kind of, it won't collapse on you. And then at the end, that'll be the last thing I'm going to break down. Then, because I'm already all the way through to here, we're going to do the rest from this side. So we're going to find the nerve root. We'll find the veins again. You can see the big purple veins there. I don't know if you guys see them.
Yes.
And so those will get all bipolared. There's a big set of veins here. Okay, so why don't you take a knife and find the disc space, because we've cut through the disc space. The disc space will be right here. Towards me. Start medial. Yeah, and then come towards you. Yeah, and I think the disc is that way. Can you cut in? That's it. So he's in the disc space now. Perfect. Okay, and then let's see if we can communicate the two. And then we would try to work both sides until we got that thing to communicate with each other.
The osteotome?
Not yet for you. You're not on your side because we're doing a hemi. Otherwise, we would do the same thing on your side. Hemi's a little harder. Okay, so now what we're going to do is you can see here, I'm going to take some of the posterior wall down. Can you guys see the posterior wall? You want to hold this? So there's the posterior wall. And so we're going to take that down, and as a triangle as well, aiming for the other pedicle. Okay. And then we'll tighten our screw now. Let's tighten those screws. So we don't want it to collapse on us. So we're going to either distract or even just tighten those down now. Okay, and now what we're going to do is we're going to finish the osteotomy on the other side. So here, I'll take that. And I want you to make a cut kind of like that, okay? So I'm going to help you. We'll retract this gently. So you've already cut into the disc. So cut into the disc so you know where you are. Good. And now we're going to make your triangle cut. You're going to meet my cut by cutting that way. And everybody can see. I want you to just hold it for an angle just so people see the angle. So you're above the pedicle. He's aiming to meet my triangle.
Visual's great.
Okay, see if you can get a little bit more. Okay, good. And take it out. Great. And then we'll finish it up from the disc side. Okay, hammer me there. Okay, great. So we're pretty much communicating now. So once you get the pituitary, I'll try to, let me get everything out of your way here gently. Okay, good. So now we're going to make sure our posterior wall is all dealt with. Okay. So we usually have extended backward down curettes, which are aimed down, and we'll take out the back wall here. Okay, you want to take all that out? Okay, and then just make sure you're clean on your side. You see that piece there?
Yeah.
Okay, great. Okay, I can get it from my side. And now we're pretty much done here. So now it'd be time to close her down. We have a big yes from, you can see the osteotomy is all mobile now, and now we're going to be closing her down. So we just take our rod. So if I'm doing it from this, we'll put a set screw in here. Is there more set screws for us? Is there a rod gripper of some sort? A rod gripper or something? So, okay, I'll try here. Okay, here, okay. Put the set screw in. And there's a compressor? No. Okay, so why don't you loosen that one up. Just on one side. And then we'll try to, no, it's just gonna compress on my side. So. They took all our instruments away. I'm sorry, everybody wants to go. What's keeping you guys away from the door? Okay, let's try again. Listen the bottom.
At some point, I would love to see an image, but I know you're working hard there right now.
Okay. Okay, perfect. So what we've done, so with a proper instrument, we'll squeeze that down more, and you can see that you can get your offset correction like this, so there's enough
Can you
release.
compress that whole side, the gap side, a little bit more? Because one thing that always troubled me about my PSOs is, so I decompressed a whole level above and below the PSO level to not have dural, and I'd always get dural infolding, or I'd get what you're seeing here, this kind of guillotining or this choking in on the adjacent segment. So what do you think when you start seeing the dural buckling? Is that a expected thing? Is that a
Yeah, it's expected. I find one level I don't have problems. On multiple levels I would. So, we obviously you correlate it with your monitoring. Want to take that out? And then make sure you're decompressed appropriately. Like here, you can see we didn't take the ligament flavum on the top here. So that needs to come out. And then one of the big mistakes people do is leave some pedicle. So that may be one of the issues. And then the other issue is sometimes there's a posterior osteophyte off the disc space that wasn't addressed when you did your resection that needs to be adjusted. So those are, we only see the back, but it's the ventral part that we're more concerned about. So.
But in principle, you'd have between those two pedicles, two nerve roots in one hole, in one foramen, right?
Exactly. So here's the other nerve root right there. Here, we'll take this off here.
Lars Lexell's magic tool.
Here, take here. Yeah. No, it's underneath. No, okay, underneath. Yeah, not that. This is what I want to.
Ligament.
Yeah. Here. Okay, we'll just show them the nerve roots. So you want to undercut. Okay. So let's find the other nerve root there. That's right here. You can see the other nerve root right there?
We're starting to see it, yeah.
That's right there. So,
Yeah, right, okay.
so obviously we close it down a little bit more and then check that you have enough of the back wall out. And usually the way you contour your rod's very important. So if I really want it closed, I'll bend it into more lordosis at this level, and that really closes it down besides compression. Is there there's no compressors, right? So, okay. So I'll try one more time. Okay. But anyways, that's the gist of it there, guys. So that's my Smith Pete. And then we'll fill in the gap. So I actually take the bone here. So I would take, in this case, for a lumbar. Do we have a big piece of bone? Is there a bone cutter at all? No. Okay, here, I'll take the osteotome. Yeah, it's a cob, yeah. I'm sorry. No worries. So, 1 second.
So, Stephen, this is on a conceptual basis. Your x-rays in your talk previously were beautiful, and this is a very nicely demonstrated complex PSO. how much do you use intraoperative imaging or image guidance to try to help you get your angles established, especially an asymmetric PSO?
Yeah. No, I don't use any.
This is all Gestalt,
Yeah.
all sort of intuition.
Yeah.
Wow.
I think at the end of the day, I consider it a release. Everything else you do with your rod. And so, this is just a different form of release. And then what I'll do is I'll take my rod, bend it the way I want, secure it from the bottom, bring it to the top, and then I force all my anchors to the rod. And so we would put a piece of bone in like that and squeeze it in, so with a press fit here. And sometimes I even have to put a screw in order to restore the posterior column. So that would be the next part that I do after. So I don't like these gaps, and so we would put the local bone, and use it to fill the gaps. Usually the gap's very small. You'd have a gap something like this, and then we'd fill it with bone here, so it would be a posterior column. And then I guess you can put your 25 rods on after that. So
We'll call him Dr. Theologist.
yeah.
Okay. Can we
thanks
do
a lot,
quick
guys.
C-arm shot, or do you think we see something on the C-arm or not? If you put like your probe into the osteotomy site, would you want to do that just for
I
illustrative
think they
purposes?
closed us out here. So,
Okay, never mind.
yeah.
Okay, Canadian work hours.
Yeah. Yeah, we're government employees like you guys are. So.
All right, well, that's beautiful. Any other
thanks a
questions
lot.
or comments from the audience? Chris?
No, I think that's, particularly for, some of these people that have kind of a severe scoliosis, that asymmetrical pedicle subtraction osteotomy is a nice way, that if you can't get enough through posterior column osteotomies, is a nice way to get correction at the apex of it. So I think that's a very nice technique that was demonstrated, and Steve showed it quite nicely.
That's very well done. Thank you, guys.
Okay, thanks, guys.
And Steve, come over here. We'll just say our final goodbyes. Give you the microphone as course chair.